Hello friends, I hope the exam went smooth for you. It was of moderate difficulty. We had a good number of questions which was discussed and asked and which you have studied, and I hope we will have good results also. Okay, let us pray and expect most of you get through with the exam. Okay, we will try to recall few questions which I have got from my friends, students like you who have let me know about who has given us the feedbacks, and we will discuss that and we will see and we will learn something from that. Okay. Now with this idea, we will see the questions which were important in anesthesia. Now this is a question which has been asked in a different perspective or a different wordings, like they were routinely asking what are the structures which are pierced while performing spinal anesthesia. This time they didn't go to spinal, they stopped outside the spinal, that is at the epidural level. So it is rather simple. You have studied beyond that also and reached up to spinal for our previous exams. So now it is very easy for you to remember what is not pierced in an epidural procedure. So we will see the question. During epidural anesthesia, which of the following layers is least likely to be punctured? That is a question. Now, if you look into this we have seen, you know, there is a supraspinatus ligament, then there is an interspinous ligament, and there is a ligamentum flavum, and then the three layers come in. This is how it comes, isn't it? Now, if you look into this diagram, you will know that this is the posterior aspect, and this is the anterior aspect, Now here you go with the needle, which is a needle which you use, 2He needle, as all of you know, we have studied it and it has been asked multiple times. Okay. So when you go with the 2He needle from posterior to anterior, you will come across all this supraspinatus ligament, interspinous ligament, and then you will start entering into the space. So you will puncture the ligamentum flavum. You can see the ligamentum flavum here, and then you see the epidural space, while dura mater is not punctured, epidural. So you stay outside the dura mater, it is epidural. Okay. And only if you go further, you pierce the dura, if you want to do spinal, then only you will puncture the arachnoid membrane, which is here, and then you go beyond that to reach the subarachnoid space to get the CSF flow, isn't it? So you very well know now that here ligamentum flavum, supraspinatus, infraspinatus, everything is punctured, but not the arachnoid. Arachnoid is not punctured. It is punctured only when you do a subarachnoid block. Okay. So that is the answer. A rather simple question, and I am sure all of you would have got through this. Okay. Now let us see the next question. Now, among the following inhalational agents used in anesthesia, which one has a blood gas partition coefficient similar to that of nitrous oxide? This is also a question that has been repeated previously. You remember what is a blood gas partition coefficient? Blood gas partition coefficient we need to know because it tells us the solubility of a volatile agent. Now, why is this important? Solubility of a volatile agent is important to tell us how fast it enters into the blood, how fast it reaches the brain, and how fast it gets eliminated. So, an agent which has got a very low blood gas partition coefficient is what is my preferred choice, because it does not have hangover effect, because it does not dissolve in blood to a great extent to produce a free fraction to bring about the result. Now, this is a concept which all of you know, I am sure. Now, we have also seen in the previous discussions, we have asked you to study the minimum alveolar concentration values. Also, you have learned the values of blood gas partition coefficients. So, now they are not asking the values, they are just asking you what is the blood gas partition coefficient of these agents in an indirect way. We know that in our discussion, see, similar to that of nitrous oxide is a question. So, for that we should know that the blood gas partition coefficient of nitrous oxide is 0.47 and the that of desflurane, it is 0.42. Some books give it as 4.5 also. Now, this is, even if you don't know the blood gas partition coefficient, there is another way to find out. We have studied in our discussions that whenever you are in search of a volatile agent which is used in daycare anesthesia, we want an agent which doesn't dissolve in blood, or we want an agent which doesn't bring about a hangover effect. We have also studied nitrous oxide is best for that as a volatile agent. Among the other volatile agent, desflurane is a choice because it has got a very low blood gas partition coefficient. In that way also, if you remember, you will reach into the answer. Now, coming straight away, if you remember these values, it will be well and good. Okay. See, we know iso it is 1.4, halothane it is 2.4. Remember, it is very high. So, that means halothane dissolve in blood to a significant extent, that even after you stop administering halothane, it will still give you the effects, or the hangover effects are there. Isn't it? We have studied this. That is why it is not to be used in daycare anesthesia, isn't it? It is not to be used in daycare anesthesia. You remember. So, another is sevoflurane. They have directly asked what is the blood gas partition of coefficient of sevoflurane in one of the previous papers. Now, see, it is a very beautiful way. We have seen it in our discussion. The blood gas partition coefficients of agents which are very, very low, which can be used in daycare anesthesia. So, now it is very clear. Desflurane and nitrous oxide, they are just like brothers with a very low tendency to dissolve in blood and can easily be eliminated. Okay. So, that is the answer for this question. Okay. I hope again you would have got this question. Coming to the third question. Under which one of the following condition is the use of bi-level positive airway pressure contraindicated? This is something which we may have to extrapolate from what we have learned. We have studied about OSA or patient with obesity, obstructive sleep apnea. We have practiced in our regular clinics that these patients need to put on BiPAP machine in the night, or CPAP machines in such cases, or COPD patient being supported with BiPAP machines, etc. We have learned in our clinics. Now, that is basically what they have asked you. Now, if you want to understand this, please see this diagram. It is very easy. Like if you normally breathe like this, you can see this is the tidal volume. Now, along with that, if you provide a positive support, so that the patient will have a continuous positive airway pressure providing CPAP. So, the tidal volume, and he will be breathing at a higher rate. The work of breathing has come down. This is to be provided for all cases where you think the work of breathing has to be taken care, like a case of OSA or those patients who need some amount of support, they can just trigger, rest everything you have to take care. So, in those cases, we can use CPAP, or whenever you are weaning the patient. This is also a CPAP is also one of the weaning modes. Now, in this case, if you want to make it much more better, like if you always provide a positive support whenever the patient is inspiring and expiring, it may produce something what is known as air trapping. Air will remain in the lung and it will cause air trapping. The lung will stay expanded without collapse, which is also not good. The peak airway pressures goes up. This happens especially in cases of COPD. So, in these cases, you want the pressure to be up when the patient is inspiring, and when the patient starts expiring, it has to come down. So, you want two levels of pressure, which is essentially the concept of bi-level pressure application. So, we have an inspiratory peak airway pressure when the patient is inspiring, and then an expiratory peak airway pressure when the patient is expiring. So, now you can see the tidal volume has significantly increased. The work of breathing for the patient has also would have come down. So, with this idea, if you come back to the question, you will understand the answer. Now, under which of the following condition the use of bi-level positive airway pressure is contraindicated? Contraindicated. See, obstructive sleep apnea, we can give no problem. BiPAP can be applied or a positive pressure can be applied. Patient with low partial pressure of oxygen, again it improves oxygenation by opening up of alveoli. Low partial pressure of oxygen, PEEP is essentially a part of it, which can again be applied. Now, high oxygen levels high level oxygen level, you can do that, no, not a harm. But because it is not although going to help much, you can apply. But remember, a patient who is sedated or unconscious, you cannot apply simply a positive pressure and wait. Even if you don't remember anything, the simple concept is whenever the airway is unprotected, you should not apply a positive airway pressure without an endotracheal tube. Like non-invasive ventilation or a CPAP or a BiPAP, these are all at risk whenever the airway is unprotected. An airway is unprotected when you have a patient in deep sedation or the patient is unconscious. That is the concept which the examiners want to check. They want to know that will you keep a non-invasive ventilator for every patient which come across your clinical career? The answer is very simple. Whenever you have a patient who has no control in his airway, who has a higher chance for aspiration, never give a positive pressure without controlling the airway. That is the whole concept, and that is why they brought this question. You understood? So this is one question which you may have to go a bit beyond what we have learned in our exams. Okay. See the next question. What is the most appropriate initial airway management option for a patient with severe maxillofacial trauma following a road traffic accident in an emergency room? They are very, very particular when they set the FMG paper to ask one question from the trauma side. Let it be a pneumothorax, let it be a maxillofacial trauma, let it be a blunt abdominal injury. These are one questions which you are going to get. This time they have come up with a maxillofacial trauma. So whenever you hear this question, there are few clicks which you will have to look, or few clues which you will have to pick up. For example, they are asking the most appropriate initial airway management. They are asking about initial airway, most appropriate, and the patient has got severe maxillofacial trauma and it is in emergency room. So these are the clues which you have. Now the best answer for this is tracheostomy. Now why do I suggested this? Now when the patient is in an emergency room with a massive or a severe maxillofacial trauma, just imagine the patient will have all this area bleeding. He has got a very high chance to aspirate from the blood which is being poured into his airway. So my primary aim is to prevent the aspiration of blood, and if he is unconscious, he is definitely going to aspirate whatever he has taken before also along with the blood. So my primary goal is to protect his airway and to maintain the oxygenation, and tracheostomy is the best method among this, because you can do it as a surgical tracheostomy or by using a rhino. It can be done as an emergency procedure. Number one, it is a definitive method, definitive airway, and third, this is very often done in emergency room. Now I don't think about oronasal or a nasotracheal intubation in this case. This is totally out, because you cannot do a scopy when the mandible is fractured. You cannot do a nasotracheal, or you cannot pass anything through the maxillofacial trauma because there will be a skull fracture underlying or a posterior injury. You may injure the maxillofacial area further by passing something through the nose. This is totally out of question, and because the patient will be extensively bleeding also. An anatomical distortion of this area will only leave you an access through the front of neck. The front of neck access can be two types. One is through cricothyrotomy and tracheostomy. Cricothyrotomy is another option which is there, but it is a life-saving procedure. It is not a definitive procedure, and it is not the most appropriate. If you don't have the facilities of tracheostomy, then probably you can go with cricothyrotomy as a front of neck access to maintain the oxygen till you get a definitive method. So my answer for this question will be tracheostomy. I hope the point is clear. Okay. Now I will just show you the photographs which we have shared about tracheostomy. You can see it is usually done at the second and third tracheal ring level, the mid tracheostomy, which is the most commonly performed one, and higher above you have the cricothyrotomy at the cricothyroid membrane, as you all know, which is usually a transient method or a temporary measure until you get a definitive method. Now as you can see, passing an oral tube or a nasal tube in this area whenever there is injury in this area is bit risky and it is contraindicated, while front of neck access is probably the best choice. So, this is one point which you have to remember. Now, the next question. A patient while performing a supraclavicular plexus block with 0.5% bupivacaine developed hypotension and arrhythmias. What is the most appropriate treatment? This is a question that has been repeatedly asked many times in one way or other, and I am sure all of you would have got through. Now, the clues in this question. First, it is a supraclavicular plexus block and the local anesthetic used is 0.5% bupivacaine. And whenever you hear about bupivacaine, we have learned that bupivacaine is known for, or it is notorious for, cardiac toxicity. Isn't it? It is known for cardiac toxicity. Now, this cardiotoxicity is difficult to treat, and the only antidote or the most effective antidote is lipid infusion. 20% lipid infusion at 1.5 ml kg per kg is the initial bolus which you give, and then followed by infusion. Don't worry about the rates about the infusion, but at least you should remember, whenever there is bupivacaine induced cardiac toxicity, the treatment is intralipid 20% at a dose of 1.5 ml per kg as an initial bolus dose, which is subsequently followed by an infusion which can be followed up for the next 24 hours. Now, this is very important. Now, here CPR is not an option because the patient is in only hypotension, not arrested. And intubation definitely we will have to do only when the patient stops breathing or goes into a respiratory arrest. And now the third question about bicarbonate, that happens only when there is a documented acidosis, then you have to give bicarbonate. Otherwise, the treatment is always intralipid. The local anesthetic systemic toxicity known as LAST is specially described with 0.5% bupivacaine in all this block. And what we do with the lipid is called lipid rescue. Lipid rescue. This is also an important question which you have learned. Now, at this juncture, I hope all of you will remember about if this is happening with lignocaine, if this was happening with lignocaine, which is actually a neurotoxic agent, in that case we would have been thinking about something else, not intralipid. In this case, we will be thinking about thiopentone as an antidote, or even propofol for 20%, 20 milligram to 30 milligram of propofol as a small dose in initial stages. So, this is it. Now, when there is underlying arrhythmias, you can also think about antiarrhythmics like amiodarone in such cases, but primarily whenever it is bupivacaine toxicity, it is only lipid infusion, 20% lipid infusion. This has been repeatedly asked in multiple papers, and I hope all of you would have got through this. Okay. Now, the last question on this regard is the drug of choice for ventricular tachycardia. Now, this is some question which, this is one question which I didn't get the full description about the question, because there are a lot of areas which needs clarification whenever you hear about ventricular tachycardia. First of all, we should know the condition of the patient, whether the patient is stable. In turn, what I am asking is whether this patient, was it a stable ventricular tachycardia or an unstable ventricular tachycardia, depends. And what is the morphology? It is a polymorphic or a monomorphic ventricular tachycardia. How is the pulse? And these are all things which comes to my mind whenever we hear ventricular tachycardia. So, in general, we can think about this. If it is purely a medical treatment, we may have to think about the drugs like that. Now, for completion, to get you an answer to this question, I would rather suggest you to go with the American College of Cardiology, or the ACLS guidelines about 2020. This is a reference from ACLS, and this is very important. I request all of you, when you have time, to go through the ACLS course, which is very, very useful. It is entirely useful and it is valuable throughout the world. It is highly valid. So, they give a definite algorithm whenever there is ventricular tachycardia. So, in that they have said that whenever there is a tachycardia, see whether it is a broad QRS segment. If it is a broad QRS segment, then it is a ventricular tachycardia. You can think about adenosine. You can think about antiarrhythmic drugs like procainamide, amiodarone, sotalol, etc. in such cases. Okay, so we can think about if it is a medical management, but if it is an unstable ventricular tachycardia, need to be electrically treated. Synchronized cardioversion is the treatment, but I don't think the question had that option. But if it is a ventricular tachycardia which is needing a medical treatment, this is probably the way which you should go about. So we will come back to you with if you get the complete question, we will get into the answer of this question also. Until then, it will be nice to cope up with your questions, and I am happy to wait for the results. Okay, thank you.